Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I'm your host, Praveen Ranganath. On this episode, we enter the world of pulmonary nodule localization with fiducials. In an effort to maximize surgical success, our thoracic surgery colleagues occasionally request us imagers to mark nodules with fiducials. The concept is akin to that used in breast imaging prior to lumpectomy or in radiation oncology prior to prostate radiotherapy. There is a huge variety of tools and techniques for pulmonary fiducial placement. Today, we will discuss a great recently published original science paper in the journal titled as follows: Preoperative CT-guided fiducial marker placement for surgical localization of pulmonary nodules. This paper comes to us from our colleagues at Massachusetts General Hospital in Boston. The lead author is Dr. Sharma and Dr, and the senior author is Dr. Amita Sharma. This paper describes a single-center retrospective study including 198 nodules across 190 patients, in whom fiducial placement was performed between 2014 and 2020. A relatively unique fiducial technique was used in this study with a rod-like gold fiducial. Over 98% of patients achieved technical success in this study, which was defined as fiducial placement within 10 millimeters of a nodule at the end of localization. Subsequent surgical localization of the fiducial and its corresponding nodule failed in only one patient. Based on these results, the authors claim that this method of CT-guided fiducial marker placement for surgical nodule localization is safe and effective. To discuss the background, results, and implications of this study, I had the pleasure of speaking with the lead and senior authors of the paper, Dr. McDermott and Dr. Sharma. Let's jump into that conversation now. All right, welcome back, listeners. I am now joined by the lead and senior authors of our featured paper, Dr. Sharma McDermott and Dr. Amita Sharma. Welcome to both of you onto the podcast.
Thank you.
Thank you very much, Praveen. It's great to be here.
Of course, and thank you all. Why don't we start by learning a little bit about both of y'all? Could you talk to us about your journey into cardiothoracic imaging, where you practice currently, and what your academic areas of interest are? Shauna, why don't you start?
So I actually did my radiology residency back in Dublin in Ireland, and then came to Massachusetts General Hospital for fellowship and did the 4-year alternative pathway there, ending with a year of thoracic radiology, where I now work as an attending in thoracic radiology. And my academic areas of interest would be thoracic interventions and also sort of thoracic oncology imaging.
And Amita?
So I started off in London for my radiology residency training, and then also came to Mass General Hospital to do a fellowship in thoracic imaging. I'm currently a staff radiologist in the Department of Thoracic Imaging and Intervention with Sharma and McDermott, and an associate professor at Harvard Medical School. My interests are thoracic intervention and interstitial lung disease.
Excellent. Well, thank you both for joining us. I wanted to point out something somewhat unique about the institution that y'all are coming from. There is intervention within the thoracic imaging department. At many institutions, those may be separated between the diagnostic thoracic imaging and the interventional radiology community. Could you speak a bit to your unique department's approach to thoracic intervention? Amita, why don't you take this one?
Yes, we have very close relationships with the thoracic oncologists, surgeons, and pulmonologists, and during our diagnostic studies and also our interventional studies. And that really helps us understand the needs of our providers and also the patients. And I think that it also helps us perform our technique successfully and also with an idea of the complications that can occur. We perform biopsies for diagnosis, but we also are involved in repeat biopsies for patients who are on clinical trials. And so we assess their response to chemotherapy on the diagnostic study, and then a natural progression would be to perform intervention during that time. We also are strong believers in the lung cancer screening program. So we have a very dynamic lung cancer screening program, and nodules are assessed as part of an interdisciplinary nodule clinic. And many of these patients then go on to CT-guided biopsy for that. And for the small nodules, we perform localization, which is the basis of this study.
Excellent. I think that's a nice segue into going into the featured paper. To review again, this is an excellent single center retrospective study that looked into the safety and effectiveness of a specific CT-guided fiducial placement to help guide surgical resection of pulmonary nodules. That said, many of our listeners may practice at institutions where preoperative fiducial placement is not performed. Could you explain what the rationale of fiducial placement is for this procedure?
Yes, I'll take this one. So as I said, we've had a strong lung cancer screening program. We've had a number of advances in CT technology, and increased utilization of chest CT has really led to identification of many small indeterminate lung nodules that often go on to biopsy and resection. Surgeons are now performing a lot more parenchymal sparing surgery rather than full lobectomies. And so they need to be able to localize these nodules well. Nodules may be benign or malignant in etiology, as you know, and so often surgeons try to limit the amount of parenchyma that's removed, particularly if you're making a diagnosis of a benign lesion. You don't want to take out a lot of parenchyma. But also in patients who have metastatic disease, you may want to limit the amount of parenchyma removed. And for early primary lung cancers, particularly in patients who have limited pulmonary reserve, we want to try and limit this. Over the years, surgeons have had a real shift from using open thoracotomies to minimally invasive surgery to remove lung nodules. And minimally invasive surgery includes things like video-assisted thoracoscopic surgery, or VATS, and also robotic-assisted thoracoscopic surgery. The reason they use this is because it's associated with a lower morbidity, shorter hospital stay. So previously with open thoracotomies, the surgeon could use bimanual palpation of the lung to actually identify nodules. But with the minimally invasive surgical techniques, there are limited access ports. And so they cannot easily palpate for these nodules and identify these nodules, particularly if they're sub-centimeter in size, they're deep in location, or they may be ground glass or part solid in attenuation. And in robotic-associated surgery, you actually don't even palpate the lung at all. So because of this difference in approach, it's led to difficulty in identifying these nodules, and often failed procedures where patients may end up not having their nodules resected successfully, or the surgeon has to convert to open thoracotomy. And so because of these reasons, preoperative localization really helps surgeons identify nodules successfully. So that's kind of the rationale behind why we're doing this procedure.
Excellent. And in terms of increasing success, as well as making sure our patients are safe while doing this procedure, what do we know about preoperative fiducial placement in terms of safety and effectiveness based on prior data? Shauna?
So here, even at MGH, we've been using gold fiducial markers for preoperative or pre-radiation treatment in both liver and the prostate, which were placed by the interventional radiology department, and even pre-radiation in the lung that would have been placed transbronchoscopically by the surgeons. And these experiences showed that the gold fiducials are completely inert and safe in the body. And obviously in the cases of radiation, they stay in the body and have had no issues. So we knew that the fiducial themselves were safe. And then looking at prior studies for the percutaneously placed fiducials into the lung, other centers such as Emory for preoperative localization, BI for pre-radiation localization, all had good success and good safety profiles for this procedure.
With regards to that, we've been mentioning different types of fiducials. Can we go into some of the details as to what the differences are? For example, in this current study, y'all described the rod-like gold fiducial marker placement. A lot of our listeners may be more familiar with the hook wire or Lipiodol-based fiducial techniques. So what are the major differences, and is one more advantageous than the other, or is there not much difference?
So you're correct, Praveen. There are many different ways to localize nodules. And in our article and previous articles, we've divided this into two main types of markers. There are the metallic markers, and then there are liquid markers. So as you mentioned, hook wires would be a metallic marker, and then liquid markers such as Lipiodol that you'd mentioned. And then also markers are identified by the surgeon at surgery by different ways. So either direct visualization, or they may require on-table fluoroscopic guidance or use of a gamma probe. So just to give you a quick summary of the types of markers that are out there, you mentioned the hook wire. That's probably one of the commonest. That's similar to the breast localization procedure, where a wire is placed under imaging guidance, and the hook is left, when we're doing it for lung nodule localization, it's left just around the nodule. And then the rest of the wire is brought out to the chest wall and left there. So you can imagine that this would require immediate resection, and the surgeon would resect it immediately after the wire was placed and would use the hook wire to follow the path into the nodule. And so the radiologist, when he's placing this, has to really limit the way they place it by choosing the shortest approach to the nodule. And the radiology schedule would really be tied very closely to the operating room schedule. There is also increased risk of dislodgement of that wire during transfer or during manipulation. So the differences between that and our fiducial marker is that our fiducial markers are these gold rods that actually fit through a coaxial needle. And so the coaxial needle is the same needle that we use for lung biopsy. We access the nodule when we're doing the localization in the best route for the radiologist. So we don't really need to worry about shortest route. We would do it the way is safest. And then once we place those fiducials, they're left in the lung. As Shauna had mentioned, we know that they are inert and safe to be left in the lung for a number of days and time. So the operating room schedule is then dissociated from the interventional radiology schedule. And this really helps both surgeons and radiologists in terms of scheduling. So that's one of the big differences. You also mentioned Lipiodol. Lipiodol is a liquid marker that's injected into the nodule and can be seen by fluoroscopy. Other liquid markers include methylene blue, which many institutions use. This is injected into the nodule under CT guidance and also injected to form a tract to the pleural surface that can be seen by the surgeon and then is used to be resected there. The disadvantages of the methylene blue technique is that there is rapid diffusion of the dye. And so again, the patient needs to go straight to the OR after injection of the dye. And also if the dye leaks into the pleura, that can affect visualization of the actual position on the pleura, and so can cause problems in localization. Another technique is technetium-labeled macroaggregated albumin, which has been used in a number of centers. The albumin is injected, the radioisotope is injected into the nodule, and then the patient again is transferred to the operating room, and a gamma probe is actually used to localize the nodule. So that's again a successful way of doing this. So our technique with the fiducials, we feel, is advantageous in a number of ways. First, that it's easily placed because it's the same technique as we use for biopsy. So all radiologists in our department do this who perform interventional procedures. You can place this deep to the nodule, and so sandwiching the nodule between the free edge of the lung and the pleura and the fiducial markers gives the surgeon an idea of the deep edge of the lung nodule. It doesn't need to go right inside the nodule. We place a couple of fiducials just in case one moves during manipulation of the lung. And as I said, the advantage is that we don't have to do this on the same day. It's also a pretty low cost procedure. It does require fluoroscopy to identify the fiducial markers. And then at the time of resection, our technologists also perform a wedge resection specimen imaging, just to confirm that the two markers are actually in the specimen before they're transferred to pathology. A similar procedure is also done with microcoils. And microcoils are used, they're the embolization coils. So these are loaded into a coaxial needle. And then when the needle is at the level of the lung nodule during localization, the microcoil is pushed through the needle using a stiff wire. It can either then be pulled up to the pleural surface so it can be directly visualized by the surgeon, or it could be completely pushed through to lie around the nodule, and then it's identified by fluoroscopy in a similar fashion to our gold markers.
Excellent. So in principle, all the fiducials are similar in that they're attempting to localize the nodules prior to surgical resection, but the approach, particularly those that involve a dissociation between the surgical schedule and the interventional schedule, are quite interesting. With that in mind, I presume that all of the nodules that are going to undergo surgical resection don't get preoperative localization. So what are the types of nodules that typically get referred to y'all for localization? And the opposite question would be, what types of nodules would not be amenable to preoperative localization with fiducials?
Yeah, that's a very good question. So the nodules that usually get referred to us are the smaller, more ground glass, or a little bit deeper nodules that the surgeon isn't convinced that they will be able to identify without fiducials beforehand. Usually they obviously know themselves which ones that they can find. The ones that they would not, and we feel that we can localize most nodules. So we're saying you want the fiducials within 5 to 10 millimeters of the nodule, and usually there is a safe plane to place these gold markers. The ones that we can't do are the ones that they don't refer would be larger or central nodules that would need a lobectomy. So any nodule that they feel can undergo wedge resection, but they're not convinced that they're going to be able to locate at the time of surgery, we can localize with fiducial markers.
Got you. And obviously y'all have been doing this for quite some time. For the interest of those out there that either may just be starting a localization with fiducial program or are interested in doing so, could you speak to the learning curve of utilizing gold fiducials relative to, say, hook wires?
Yeah, so we used to do hook wires prior to the fiducial localization, but it was very infrequently done, mainly because by the time the patient went from the interventional room up to the OR, quite often the hook wire had been dislodged. Now there was always a track and there was always like a little hole in the pleura that they could use that, but I think we ourselves weren't very comfortable with it and the surgeons weren't. And that was why we decided to look for other options for localization, and Amita championed this gold marker fiducial localization. And from the point of view of the learning curve, this is one of its biggest advantages. We use the same needle as we do to biopsy. You can even do a biopsy at the time of the localization. And the thing to just get used to was so when we do our biopsies and localizations, we like to use a saline seal we place a few drops of saline within the introducer stellate, just in case we're in a vein or somewhere we don't want to be, to reduce the risk of air embolus. So it's just getting used to placing that and then the tiny little marker in. But it was, once we got used to that, it was a very quick, easy learning curve. And as Amita was saying, everyone in our division that does biopsies are happy to place fiducial markers.
Excellent. And with regards to the technical success, I think the results speak for themselves. Preoperative localization was successful in greater than 98% of the cases, the nodules that y'all had intervened upon. Technical success in this case was defined as at least one of the fiducials being within 10 millimeters of the nodule at the end of the fiducial placement procedure. That said, in those few cases where technical failure was reached, it seemed that fiducial migration was the main culprit. Can you talk about what fiducial migration means and how interventionists may potentially mitigate fiducial migration?
That's a great question, Praveen. So fiducial migration was very rare. It only occurred at the time of the procedure. So once the needle was successfully removed and the gold markers were demonstrated to be within the parenchyma, we did not see any late cases of fiducial migration. And this really allows us to perform this procedure on a separate day to surgery. So that gives us one of the great advantages of using gold fiducial markers. We actually had 4 cases where at least one of the gold markers fell back into the pleural space along the needle tract. And we had 1 case where the fiducial marker was inadvertently placed within a small pulmonary vein. So the 4 cases of pleural migration, when we evaluated that, falling into the pleural was more likely if the needle crossed the fissure during the procedure, or if there was visible tenting of the pleura rather than piercing the pleura cleanly. And this was especially important with subpleural nodules. So we recommend that it is advantageous to use a longer intraparenchymal course when placing the fiducial markers instead of a shorter tract that might be more tempting if you have a subpleural or a peripheral nodule. And since the migration occurs during the procedure, it's easily recognized, and we would recommend just continuing with the procedure and then placing another fiducial deeper in the parenchyma with, if possible, a slightly different angle for the needle trajectory. Once the fiducials are in the pleura, they're entirely asymptomatic, and sometimes the surgeons choose to leave them there if it's not easy to fish them out. The second complication, which we saw in 1 case, was where the fiducial marker was placed within a pulmonary vein, and this, as you can imagine, is potentially more serious. As you know, blood would flow from the pulmonary vein into the left atrium and the left ventricle, so the fiducial marker would do exactly the same, and then from there go into the systemic circulation. So in one of our cases, we had been asked to place the fiducial within a ground glass nodule, and there was actually a very small vein going through the middle of the nodule, measured only 2 millimeters in diameter. So the needle tip was right adjacent to the vein, and we immediately saw on our post-procedure image that the fiducial marker was not within the nodule. It was then identified to lie within the left atrium. And later, when the patient was changed into a dependent position, the fiducial moved into the left ventricle. It actually stayed within the wall of the left ventricle for almost 2 years until the patient's demise, and the patient was entirely asymptomatic from that. So in order to prevent possible placement in a pulmonary vein or a pulmonary artery, it's important that the radiologist visualizes all the structures around the tip of the coaxial needle before placing the fiducial. So as those of you who do interventional procedures know, the coaxial needles have an inner stylet with a sharp tip, and this extends a couple of millimeters beyond the flat end of the outer cannula. So before deployment, we always perform a CT image with the inner stylet pulled back by a few centimeters so that we can see exactly where the end of the outer cannula is, and obviously make sure it's not within any structures such as a vessel. Our procedure is very similar to our biopsy procedure in that we drop a few drops of saline into the outer cannula as we remove the inner stylet. We do this just to prevent risk of air embolism. And then we drop one of the fiducials through The fiducials are only 0.8 millimeters thick, so they fall easily through the cannula. And then we use the inner stylet to make sure that the fiducial moves away from the end of the needle into the parenchyma, but we don't push it deeper than that. So it really stays where we want to place it. Within our study group, we didn't have any fiducials that fell into the airways, but this is also a theoretical possibility. If the tip of the needle crosses into the airway, then the fiducial can go into the airway. It's usually of no consequence. The patient just coughs it out. But if it's recognized at the time of the procedure, then a small adjustment of the needle trajectory and then placement of another fiducial is adequate. Airway migration, however, is far more common when these gold fiducials are placed bronchoscopically by our interventional pulmonology colleagues or thoracic surgeons, because by bronchoscopy, the fiducial would be deployed very close to the airway, and there would be a tract between the airway and the fiducial, which can result in either immediate or late extrusion of the fiducial through the airway.
Excellent. Well, for those of us that get involved in percutaneous pulmonary interventions, beyond fiducial migration, I think pneumothoraces are really one of the feared complications. In your study, you report an approximately 20% pneumothorax rate identified at the time of procedure, about a quarter of which required chest tube placement. So in light of this, because this is an additional procedure that a patient would have to go through prior to surgery, can we weigh the benefits of preoperative fiducial localization against the risks of pneumothoraces?
Yeah, so just under 6% of our patients required a chest tube placement. But when you're comparing this to patients who undergo wedge resection, after which you obviously have one, if not two, larger chest tubes, I think the risk of the pneumothorax is worth it compared to undergoing a wedge resection and missing the nodule, or undergoing a VATS procedure that has to be converted to open and a bigger procedure to resect the nodule. And in our case, we'd say 25% of our patients underwent surgery the same day as the localization. Obviously, one of the advantages is you can disassociate it from the surgery, but some surgeons prefer to do it all in one day. So in those cases, if you put in a chest tube, it doesn't really delay their stay because they're going straight up to the OR then. And in the other cases that required chest tubes, they usually were removed the next day. So it was a little inconvenient for the patient. They stayed in overnight, but I think overall, compared to missing the nodule or conversion to open procedure, I think it was worth it.
Yeah, and with regards to achieving surgical success, impressively, I think it was really only one nodule that was unsuccessfully localized at surgery in terms of fiducial placement. So how does that excellent success rate for gold fiducials compare to those of other nodule localization techniques?
So I think that the nodule localization techniques are across the board really successful. If you look at the published literature, most of these techniques have greater than 90% success rates. And every institution swears by their technique. So I think they're all universally successful. Some of them have slightly longer learning curves, and there are institutional preferences. Obviously, some require fluoroscopic guidance to resect the markers, and that can add an extra dimension to the operating room workflow. So it really depends on your institution. And I would just say that accepting one technique and using it and learning from it, I think that is going to be infinitely more successful than not having a nodule localization technique within your institution.
As you had mentioned, institution-specific preferences are a critical, important point here. The difficulty, though, is how does one apply the literature from one institution to another? And I guess that sort of brings me to discussing any potential limitations of the work that y'all have done. Beyond knowing that this is a single center study with a retrospective design, are there any other important limitations of the work that y'all have published that our listeners should be aware of?
I don't think there's any other limitations of the study other than what you've just mentioned. I think obviously a limitation of our procedure again is that it's one that does require fluoroscopic guidance at the time of the surgical resection. So there is a small, tiny increased radiation dose both to the patient and to the surgeon. But I think from the study point of view, I think the biggest limitation is the single center retrospective. So obviously in the future, you would like to see if other centers would have the same success as we did doing this procedure. And also we have suggested to our surgeons here trying different techniques to see if we could compare them and maybe do like a randomized trial of which technique is best. But unfortunately, our surgeons are very happy with the one that the fiducial marker localization, and do not want us to attempt any others with either technetium or the methylene blue.
Well, yeah, it sounds like your institution has a very well-oiled machine in terms of how they approach fiducial placement prior to surgical nodule localization. But in that same light, in the interest of the science behind it, are there any plans that either y'all or the community has in terms of future studies with regards to either this specific technique or localization in general?
As I said, hopefully we can convince them. I think some of us are interested in trying the liquid localization because it's different, but it also doesn't have that risk of migration or embolization. Obviously, they have other risks, but again, we just have to convince some of our surgeons to get on board.
You know, I'm familiar with other techniques of localizing nodules that may be intraoperative. Could you speak to the advantages of radiologically guided techniques prior to the operating room relative to those intraoperative techniques?
So I think that the advantages of doing a radiological localization before surgery is that the marker is there and the surgeon can just efficiently and effectively remove the nodule that has already been marked. By doing a procedure to localize the nodule during the surgery, it could increase the time of the actual surgical procedure and increase utilization time of valuable operating room time. So I think our technique of localizing prior to the procedure is a very cost-efficient and time-efficient way of approaching nodule localization.
For our listeners out there that are in institutions that are planning on exploring fiducial placement or are in the early stages of it, could y'all provide some advice, not only for the thoracic imagers, but also the surgeons and the oncologists that may be there for how to help advance their system to be as well-refined as yours?
Shauna may want to add things, but I think that every department that performs minimally invasive surgery should have the support of a radiologist who offers a localization technique, just because of the inherent challenges that we mentioned when performing minimally invasive surgery. So if centers are not performing this, I would encourage interventional radiologists to really discuss with their surgeons these options and always have direct communication when you perform these procedures, not just during the initial phases, but even later on when you're an established program, because that communication of what the surgeon needs and how we can offer the best localization is really important in the success of these programs. The other thing is there are many centers throughout the United States and in fact internationally that already perform these localization techniques quite expertly. And so I would encourage radiologists who are thinking of starting to look at these techniques, decide which one, and then contact the centers, because we would all be delighted to speak to people who are thinking of setting up this program.
Yeah, I agree with everything Amita said there, and especially in places that have a robust lung cancer screening program, because you have these smaller nodules that they're going to want to resect. And just to plug one of our radiographics papers, which we discussed different types of preoperative localization of nodules. And there's obviously multiple authors from multiple different institutions and that do these, and a great place to start regardless of whichever procedure you decide to do in your institution.
Brilliant. Well, Shauna and Amita, thank you very, very much for joining us and sharing your time and expertise. Any last thoughts before we close?
No, I'd just like to thank you for inviting us to discuss our paper. And I'd also like to recognize all the other centers that do this important role of preoperative localization and encourage people who are not doing it to look into this.
I agree with everything Amita said there, and thank you very much for this opportunity.
Of course. Thanks again. And to our listeners out there, of course, thank you for tuning in. If you like what you hear from us on the Radiology Cardiothoracic Imaging podcast, please rate, review, and subscribe to us. We will see you next time.